Good morning. Welcome to meeting 4 of the Budget Review Subcommittee on Human Resources. We appreciate everyone's indulgence as we work to reschedule our previous meeting held on September 8th because of the call of our special session. And as a reminder, remote access is allowed to all meetings for 2021 interim session. Members are provided a Zoom link to access the meeting remotely. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the Secretary call the roll.
Senator Adams. Senator Alvarado.
Present remotely from my district.
Thank you. Senator Berg. Senator Carroll.
Present in the room.
Representative Bowling.
Present from my district.
Representative Frazier.
Present from district.
Representative Gibbons-Prunty. Representative Sheldon.
Present from my district.
Representative Weber. Representative Westrom. Representative Wilner.
Here in the 35th District.
Thank you. Senator McDaniel. Representative Petrie. Representative Reed. Representative Poor Mosier. Co-Chairman Meredith.
Present in the room.
Co-Chairman Bentley.
Present in the room.
Thank you.
Thanks, everyone. Next, we have approval of the minutes from the August 4th meeting. Is there a motion?
I'll make a motion.
Motion by Co-Chair Bentley, seconded by Senator Carroll. All those for the motion say aye.
Aye.
Any opposition? Right. Minutes are approved. Before we begin presentations for members participating remotely, please remember to mute your microphones. And if you have questions, certainly we'll acknowledge that when it comes time for questions. But this morning we're going to have a presentation from Commissioner Lee and Steve Bechtel, Chief Financial Officer with the Department of Medicaid Services. They'll provide us with fiscal year 2021 closeout numbers, outlook for fiscal year 2022 for the Medicaid budget. So, Commissioner, if you're on board, and Steve as well, please identify yourself for the record.
Good morning. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
And good morning. I'm Steve Bechtel. I'm the Chief Financial Officer for the Department for Medicaid Services.
Appreciate having both of you this morning. Looking forward to your presentation, and we'll ask members to hold your questions till after the presentation, please. So please proceed.
Thank you. So just a little bit of a glance at Kentucky Medicaid 2021. We served approximately 1.6 million Kentuckians in 2021. We have a breakdown of the number of individuals by category. For example, you can see we had a little over 101,000 in our CHIP program, 627,000 covered under the Medicaid expansion, and 903,000 covered under our traditional program. And while these numbers are large, and we're very thankful that the department and the program is here to serve those individuals, we definitely know it's not really something to be boasting about that we have 1.6 million Kentuckians eligible for our program, because it's just a testament to the fact that we have this many individuals living at or below the federal poverty level, including a little bit more than half of our children living in poverty. And just as a reminder, for the poverty level for one person, that's $17,774 per year that they have to be at or below in order to qualify for Medicaid, and that is prior to taxes. We also have over 59,000 providers enrolled serving our population, and we're very thankful that we have this provider base to help ensure the healthcare needs of our population are being met. In 2021, our budget was $14.7 billion. That includes both administrative and benefits. Next slide, please. We have a little bit of our eligibility experience here. You can see that traditionally we've had some churn in the program overall, but in April of 2020, you can see that COVID definitely had an impact on the number of individuals requiring services through the Medicaid program. We have seen a little bit of a slight drop off in July of 2021. we are currently covering a little over 250,000 more individuals in the Medicaid program than we were covering in March of 2020. So we have had a little bit of a decrease in that, mainly due to presumptive eligibility, individuals dropping off of the rolls. Presumptive eligibility is a temporary enrollment into the Medicaid program while individuals can complete that full application. Presumptive eligibility allows those individuals to have access to care, and it also allows providers to receive payment. But due to the temporary nature of the program, if the individuals do not complete a full application, they do lose their eligibility. We currently have around, I think, 2,000, a little over 2,000 individuals enrolled in our presumptive eligibility program at present. Next slide. And now, as we go into our budget, I will turn it over to Steve Bechtel, our Chief Financial Officer, to walk you through our budget.
Thank you, Commissioner. Can everyone hear me okay?
Yes, thank you.
Okay, I've got this headphones on. I just wanted to make sure that you can hear me clearly. But I went back to the eligibility graph there that the Commissioner was just talking about. I just want to point out, I mentioned this in another committee setting in the Medicaid Oversight Committee, but I know some of you are not on that committee. So I just wanted to point out one thing is when we got the 6.2% increase FMAP by CMS, when they gave that to us, they had an expectation, they had a condition called maintenance of effort. And what that means is that we had to provide continuous coverage for individuals. We could not disenroll anyone. And that's why you see prior to the pandemic period, you see that churn up and down, but then you have a steady line straight up. Starting in April all the way up through, I guess, sometime October. But there was only three reasons or three cases or situations, I should say, that CMS would allow us to drop someone from the rolls. And that was due to the death of the individual or the individual moving out of the state, or that the individual actually requested to be disenrolled from the program. So that's why you see that pretty much steep kind of slope there, straight increase with no churn. Then in late in 2020, CMS came back out with some updated guidance, and that updated guidance said that they did not intend to include the presumptive eligibility or the temporary eligibility programs in that maintenance of effort. So that's when we started dropping off some of the PE members. You'll see, because they get two PE, what I call segments in a calendar year. And so that's why you see that up and down, slight up and down, and that we had still an increase from that period, from that updated guidance to the end of the state fiscal year of 21, but not near the steep slope that we had during when we had the maintenance of effort on everyone. So I just wanted to point that out real quick to you guys so that you can see why that had no churn whatsoever. But now we do have a little bit of churn. And you can see, like Commissioner said, on July 1st, we had some PE members drop out, about 120,000. Presumptive eligibility members dropped off on July 1st. They exhausted their 2 calendar year segments. But you can still see there's a slight increase continuing since then. So I just wanted to point that out because, eligibility is one of the main things that drives our budget, along with reimbursements. So if you remember my triangle from a few years ago, one of those triangle ends was the eligibility. And so as eligibility grows, so does our budget. We are, like she said, unfortunately, we're thankful we're able to provide those services to those individuals, and that we have a program here to do that. But at the same time, we're not boasting about it, like she said, because, it's nothing to boast about when you are the 3rd highest poverty level in the nation. We're only behind Mississippi and Louisiana in that. But with that, as well as, and we're all we're still one of the sickest populations in the nation as well. So when you combine those two factors, obviously eligibility is going to increase and stay at high levels. So I just wanted to point that out real quick before we get going into the actual numbers. I'm a numbers guy, so you'll have to, I may, as Senator Meredith has said in the past, I throw it as a fire hydrant at you. You may I'll be glad to take any questions you may have after the presentation. This first slide, I just updated from what we've provided in the past. What I've provided you here is the actual expenditures from 2018 through 2019, and I broke it out by general fund, restricted funds, and our federal funds. But then also you can see the total. So you can see that in 21, we had, when compared to 20, those are the two areas I want to concentrate on this slide, is looking at 21 compared to 20. You can see on total funds, we had an increase of about $2.5 billion spent on the program. And we'll go into details on this here in a second, but that's about a 21.5% increase in 21 compared to what we spent in 20. But you can see that the majority of that 2.5 billion was in the federal funds. When you look at the federal funds, 9.4 compared to the 11.7 that we spent in 21, that's a 2.3 billion. That's 91.4% of the overall increase that we've seen. That is, you know, I know that's still tax dollars, but those are federal tax dollars that we're able to bring into the state and make sure that our state is receiving funding. And you know, I don't ever like to call ourselves an economic engine by any means, because that's not our goal. That's not our mission. But a lot of times Medicaid is the ones who are looked at to help providers out and in crisis or needs. And so we were able to bring in those federal dollars to help our providers within our state. The other thing that I'll show you here is the $185 million increase, roughly $185 million increase on the restricted funds. When you look at 20, it was 478 and 21 is 662. That's about a 38% increase. That is mainly due to the HRIP program on the hospital rate improvement program. I believe it's House Bill 183. And that's due to the assessment piece that the hospitals pay. They cover a lot of the state, they cover the state portion of that payment. It's over $1 billion that we pay them, but they also pay the assessment to cover the state. And so that does not, we use those funds as restricted funds so that we can restrict it to that program. And then in general funds itself, we had about a $35 million increase, which was very slight. It's 1 point. I know that's, I guess it's how you define slight, but in Medicaid, $35 million is very slight in 1.8%. But I know it's not slight when you're talking about to the taxpayers. But when you're looking at the increase, it's a very slight increase of a 1.8%. So what I want you to get from this is, yeah, 91.4% was of the increase is federal dollars, 8.6% is state funds, with 7.2% of those state funds being restricted fund appropriations, and restricted fund dollars being spent. This slide here just shows you by general funds, restricted funds, and federal funds, what our actual expenditures were compared to what our appropriations were. You can see that we spent 100% of our general fund allotments, general fund appropriations. And we also spent 93% of our restricted fund appropriations. So in the long story of this, the total dollars we actually expended or spent 99.4% of the budget that we were given. And that's I know that's a lot of money. I don't discount that at all, but during this pandemic and the things that we have been able to do with those funds is simply amazing to me. I've been with Medicaid for 20 years, and this last year and a half hasn't been easy living on anyone. But at the same time, it's been a very difficult time in managing a budget that we were given. So because we want to make sure that we help every provider that we can, but we also have limited resources to do that. I know it seems like we have a lot, but every penny you can see, $93 million of the $14 billion that we were given in budget was not spent. But so that means every other dime was given. And I will be honest with you, I take my job pridefully. I've been doing this for a while. I've met with several of you before. And, one thing that I make sure is that we're being good stewards of the taxpayer dollars, and that we're trying. And Commissioner will tell you that whenever we're talking about a new program, my first thing out of my mouth is, well, do we have the ability to sustain this? Do we have the budget to sustain this? Will we have the funding to sustain this? Those are the things that come out of my mouth with every conversation that I have on programs. So I don't want you thinking we're just spending this willingly, like just flying it out, but I just wanted you to know that there are good decision-making, good thought process that is going through every decision that we make in the department. This next graph will show you, I call it my Pacman graph, so to speak. You can see that 75% of our total budget, the $14.4 billion, it was spent with managed care. Now, I want to caution you on that because some of these funds, a lot of these funds are, maybe I should say, paid to or through the managed care organizations, because we have some supplemental payments, such as the HRIP program, such as university directed payments, such as House Bill 8, the ambulance provider payout. Those are supplemental payments that we pay through the managed care organizations, which means it's just a pass through. We're giving them the funds and they have to pay it out. That's something CMS requires us to do on our supplemental payments. They only allow us to carve out one supplemental payment. And the only supplemental payment they'll allow that to happen is the GME, which is the graduate medical expenditures that we did carve that out. We've carved that out on July 1st of 2020, and we are paying that strictly through an enhanced program that we got approved through CMS to pay that out solely through the fee-for-service arena. But so I just want to caution, when you see the 10.8, a lot of that, not a lot of it, but a portion of that, a big portion of that is the supplemental payments that we have passing through them to our providers. The other 25% of the funds, 24.8, was spent in our fee-for-service arena. And we've highlighted some of the key areas here: nursing facilities and alternative community care, which are also known as the waivers programs. You can see those two are the highest paid amounts in our fee-for-service arena. And then we have also included transportation, dental. I know dental is a hot topic right now, so I wanted to provide you that information: pharmacy, ICF, IDD, and hospitals. The one thing I do want to comment and maybe point out to you is the all other column down there. It shows a negative 27 million. Let me explain that. So we bucketed everything else, like podiatry, vision, things like that. We bucketed all those category service in this all other, but we also included our drug rebate because those are offsets to expenditures. And so the drug rebate is basically, we're showing here of all the other expenditures, such as our Part A, Part B, Part D premiums that we pay for beneficiaries, for our members, that drug rebate, we received more drug rebate than what we had in expenditures and all those other columns and all those other category services. So I hope that's clear. If not, I'll try to explain it a little differently or a little better if y'all still have questions on that later.
So Steve, before you move on, I'd like to point out on that slide, the dental and the pharmacy costs that you see over on the right side of your screen are those costs provided by fee for service only. Those facilities, those provider types did receive other funds through the managed care. I just wanted to make sure that you understand that's not the total that those providers received. It's just those for individuals enrolled in our long-term care communities and our waiver programs. So that's not their total expenditures.
Yeah, thank you for pointing that out, Commissioner. I should have been more clear on that. What we're showing here is what we've paid through the fee for service, through our fee for service claims on all of those in that 25% quartile. They also received, except for nursing facilities and alternative care, like she said, the pharmacies, the hospitals, the dental and stuff, they're also in that capitation payment that we paid through to the managed care organizations. This slide here, we're going to go in depth about the 2.5 billion real quick. The 2.5 billion increase. Why did we see that increase in 21? And we'll go more in depth on the managed care line here in a second. But NEMT, you can see that our non-emergency medical transportation that we contract with the transportation cabinet to process and to manage. You can see that we had a $39 million increase over 20 when you compare 21 to 20, and that's about a 38% increase. We pay them a per member per month as well to each one of those brokers in those regions to provide that care and provide that delivery service to the members that we serve. And so basically this increase is solely tied to the increase in enrollment that we've had over the last year compared to 20. So you can see that it's a large increase. It's 37.8% increase, but that's tied solely to the enrollment increase. I mentioned drug rebate just a second ago. You can see that drug rebate, we had about $168 million more in drug rebate in 21 than we had in 20. This is kind of you can see a trend basically on the drug rebate. I've gone back and looked at it, and in the odd number years, we have a high dollar amount. It's anywhere from 750 to 800 million. Now, the 827 is a little more than what we've received anytime, but it's normally in the odd number years, like 2017, 2019, 2021. It's always around the 750 to $800 million range. But then on the even number years, and I don't have any rationale or any reasoning behind that, but I'm just reporting to you the data and the trends that I'm seeing in the data, is that in the even number years like 16, 18, and 20, we were around 650 million to 700 million, but it's mainly around 650 million that we received in those even number years. So I anticipate if we are still following that trend, that in 22 that we will not have, we'll have less drug rebates than what we had in this year. I hope I'm wrong, because that helps us offset a lot of our expenditures, but that's what we'll be monitoring that pretty closely. The other thing is the fee for service line. You can see it's a 1.8% increase. It's 75 million. Some of that is tied to the $29 add-on that was placed in House Bill 192 for our nursing facilities that we're managing, that we've implemented and got approved. So some of that is that increase. But let's talk more about the managed care line. The managed care line is of 2.5 billion. It's pretty much the entire amount. But I wanted to point out, like I told you earlier, there are some supplemental payments. But first of all, there's about 51.5% of that increase is due to increase enrollment. We've already talked about how our enrollment has increased greatly. We're paying a per member per month. So for each month that those members are, the eligibility is high, we're having to pay that per member per month cost, regardless if they get a utilization or not. Now, I will tell you there is a 90% MLR still effective and still assigned to this, but that MLR calculation is always done in a prospective manner, which means we won't be looking at the 90% until after the end of the period. So we'll be looking at that, I believe, first of the year of 2022 for for that period that in which these payments were made, to make sure that the 90 cents on the dollar was paid for benefits. But the other thing that it's doing that caused this a large piece of this is the program change, the programmatic changes that have been done. I know that there was one bill that we had to increase the cap payment because the CARES, what was it, for DME services, where we had to follow that House bill and we set a floor payment on DME services. We also had other things that we did as a result of the pandemic, such as DRG. We adjusted the DRG. When we adjust the DRG, so does the MCO. So some of that was tied to that increase. The other increase, now when I'm saying 683 million on that next dot, that next point, for House Bill 183 that was passed in the 2021 session for the HRIP program, that was 683 and increase over what we spent in 20. All right, so we paid almost 700 and something. It was in the 700, almost $800 million in HRIP payments in state fiscal year 21. However, it's always a lag. There's always a quarter lag. So we just paid another 287 million to the hospitals in this program, which put us over the $1 billion mark for, if you look at it as a service date versus the paid date. So I just wanted to point that out, that 683 is just the increase amount from 21, what we paid over 20. And the reason for that is, we started House Bill 320 in I think it was the 2020 session or maybe 2019 session, where we paid this HRIP program using an upper payment limit methodology. But then House Bill 183 that was passed in the 2021 session increased that up to the average commercial rates. So that's why we had that increase there. The university directed payment also, we moved to an average commercial rate, but that 332 million is due to a lag, but that's also the amount that we paid in additional funds in 21 when compared to 20. The other thing is there's been some hospitals that the universities have gone into agreements with, such as University of Louisville has gone into agreements with Jewish and Norton's, and University of Kentucky Hospital has gone into an agreement with King's Daughters. And so when they do that, it brings those hospitals into that program. So that's another reason why that increased. The universities paid the state portion of those payments, as well as the hospitals pay an assessment to cover the state portion of their payments. And what I'm giving you here is total dollars, is total funds. And then the last thing I'll mention is we had a $26 million increase due to House Bill 8, which is the ambulance per trip add-on that was passed in 2020. We had to get approval through CMS, and we did not get that approval until March of this year of 2021. There was a lot of going back and forth with CMS to get that approved, but we did finally get it approved, and it was retroactive back. And so that's why you see that $26 million increase there. I know there's a lot of information, and so if you have any more questions on that, I'll be glad to answer those here in a minute. The next slide is a per member per month slide. It shows you that 17.8% increase. It shows you by our Medicaid population, or our traditional population compared to our expansion and CHIP populations. You can see that we did have an increase in 21 over 20, like we have said before, but the majority of our increase was in the expansion line. So let me talk about that real quick. Is in that expansion line is including those PE numbers because of the poverty levels at which that they are in. We had to, for CMS purposes on the CMS 64, report those under the expansion population. So that's why you see that big, huge jump. So then if you move down to the bottom, you can see how that changes to PMPMs. Obviously, our traditional Medicaid and our CHIP increased. Those are our higher utilizers. Our expansion population and the PE population, they don't have as much utilization, as often utilization as our traditional population. And when they do receive those services, it's not as expensive, so to speak, as what our traditional population receives. And because, just to be frankly honest, our traditional population is our sickest and most vulnerable population. So yes, they're going to have a higher dollar tag, higher price tag tied to their expenditures. So, but I just wanted to point out that yes, we had the higher eligibles in expansion, but our PMPM actually decreased in 21 for expansion, and that's due to the utilization that I was just talking about just now. Before I go into this next slide, I just want to talk about present. This is not an exhausted list. This is just to give you an example of what we've been doing for help our providers during the public health emergency. And before I go into that, I just want to, if I may, just take a brief moment and just say something about our staff at Medicaid. Our staff at Medicaid have been very dedicated. I told you earlier that this last year and a half has not been easy living for anyone. And our staff, we may not be on the front lines, but it doesn't take the mental anxiety and the mental stress away. Our mental stress and our mental anxiety for our staff is just as large as anyone else's. And so I just wanted to point that out, that these programs I'm about to go over, in the 20 years I've been here, I'm so proud of our staff, and our staff have really worked very hard and diligently. The things that we want to implement, these programs that we want to implement, they don't happen overnight. It takes a lot of effort. I talked with you just a second ago about House Bill 8, how we had to go back and forth with CMS. There's a lot of that going on behind the scenes that a lot of people just, I don't think, realize takes place in the Medicaid program. So I just want to give them props and give them publicly the appreciation that they need, that they deserve, frankly, because they have worked really hard, and I'm so proud to work with them on these measures. So that being said, I just want to go into a few of the things that we've done. Presumptive eligibility is what we talked about earlier, and that's where we expanded the PE enrollment process, and it allowed Kentuckians to get that access to Medicaid services without having to wait that entire application process. And one thing that it does do that I don't think a lot of people understand or realize is that by doing that, it also helped reduce uncompensated care for some of our providers, because if we did not do this, those services would have still been sought out by those individuals, but it could have been uncompensated to our providers. So it did help reduce some of the uncompensated care during this time. Prior authorization requirements, we eliminated those for COVID-19 related services, including hospitalizations and office visits. That's one of the things I was saying. It's not just a flip of a switch. There's systematic changes that has to go forth and take place. And so our staff was dedicated, and we were able to get that accomplished. The DRG, the diagnostic related group reimbursement, that's what we pay hospitals. What we did for that is we updated the DRG to a more updated version of the grouper, which included diagnosis codes for COVID-19, and then we implemented a 20% add-on to the weight of any DRG that was assigned to a claim that had a COVID-19 diagnosis code. One thing we did for pharmacies was we allowed early refills of 30, 60, and 90-day supplies. Telehealth is something that we are looking at wanting to continue even post-pandemic, because we want to encourage, and we did this to encourage and expand we encouraged and expanded the use of telehealth services through our providers But it's been amazing what we've seen from the telehealth services that are being delivered. But what we were trying to do with that was to limit the exposure to people in the in-person trips to medical facilities. But what we found out is that there was a lot of people that not going to the doctor, but they would be more willing to do a telehealth visit. So we're exploring those even post-pandemic on those services. The next slide is just a few more things. Cost report process. We did extend the due dates for cost reports to try to ease the administrative burden on providers. We extended that 6 months. That was consistent with what Medicare did what CMS did on the Medicare cost report side. Recoupments, we allowed providers that had owed funds back to the program that we may be recouping on through accounts receivable documentations, that we allowed them to request stays on those recruitments if they were having cash flow issues. We worked with the Department of Revenue. That Department of Revenue intercepts Medicaid dollars to collect some of their outstanding receivables on their end from some of these providers. And so we worked with the Department of Revenue to have that temporarily discontinued so that the cash flow of providers could still, it would not hurt the cash flow of the providers, especially during this time. Nursing facilities, we implemented several things for nursing facilities. We did a $270 add-on for COVID positive patients. We extended the bed holds, and what that is if I may put it in my my words, my way I can understand it is that when a person in a nursing facility gets put into the, he or she goes to the hospital, we pay them to hold that bed open for them people. So we pay them the per diem amount for 14 days. We extended that to 30 days, and I believe we were few, if not the only state that did that in the nation. But maybe a few states followed our lead on that. DMS, we also increased the bed reserve reimbursement from 50 to 75 when they weren't at their consensus levels. We like I said earlier, we did implement the $29 add-on that was put in House Bill 192 in the budget bill to address the PPE equipment, the COVID testing, and the staffing issues. And one thing that we did that you can't put a kind of a dollar with, we did streamline the residential application process by accepting those client statements as their verification of assets instead of going through the entire process of verifying those assets. So
Steve, if you could go back to the previous slide a minute, I just wanted to point out and just thank the legislators too for the $29 add-on. I know the providers were very thankful for that. The legislators were very instrumental in passing that. We have been receiving some questions from providers regarding how long that $29 add-on will be in place. And it's our understanding that the language in the budget bill states that the $29 add-on is in effect until December 31st or the end of the public health emergency, whichever is earlier. So that $29 per day add-on will go away on December 31st if the public health emergency continues. Additional action will need to be taken in order to maintain that $29 per day add-on.
Okay, thank you. And just further, that is the way the nursing facilities bill, they bill retrospectively. So that last payment will be made in January, but it will be for the December services ending in 12/31 of 2021. So that's it for we have two budget appropriation units. I just went over the benefit budget appropriation unit. Now I'm going to this is really quick, over the administrative budget appropriation unit. It's got the same kind of slide that we had on the benefits side. I showed you the actuals 18 through 21, and when we concentrate on the 21 over 20, we saw about a $21.7 million increase in total spent on 21/20. But majority of that, or 14.7 million of that was tied to the federal funds again. And I will just say that it's a little bit different than benefits. We get several different FMAPs, federal matching percentages, and it's based on the job duties. It's based on the duty. If it's a DDI, which means a design, develop, or implement of a IT system, we do get 90-10 on the front end, 90% federal dollars, 10% state. And then it goes down to 50-50, all the way down to 50-50. Sometimes we get 75-25 based on based on the situation, but most times we go down to 50-50 on the admin. Excuse me. I had a little tickle.
And so I just want to point out too, these administrative expenditures are just on the fee for service, and that's the administration of the staffing here in the cabinet. Some of our contracts, it does not include in any administration in the managed care contracts.
Correct. That is correct. Again, based on just to kind of mirror what we did for the benefits, I'll just show you that we were 93.5% is what we spent of our budgeted appropriations and expenditures. I can tell you that we did not push any payments in admin or benefits. What that means is that if we had an invoice for it in admin, it was paid in 2021. There was nothing that rolled over to the next year. On benefits, we do not have what they call a prudent pay. We do not have that implemented any longer. We pay that when we get the claim, when we run that claim process, when we run our financial cycle. If we have a paid claim in the system, you got paid. You didn't have to. We didn't hold that claim for 17, 19 days before we released it for payment. We did not push any managed care payments. We did not push any NEMT payments. So we've worked hard to get all those caught up. And so we did not push anything. So when this admin, when I'm looking at this, yes, we had $15 million left over, 13.4 federal dollars and 1.9. And the reason why we may have had that is the timing of which some of these IT procurements and things are going on that maybe did not happen in the timeframes in which we thought was going to happen. The last slide is, let me reword it a little bit. I know in the past, Senator Alvarado, you've not liked this slide much because you say it doesn't depict the managed care admin. So let me just say it this way: is we had two appropriation units in Medicaid budget. We have the benefits appropriation unit and the admin appropriation unit. And what we've spent is of our total budget, 98.5% happens in our benefits budget in our appropriations unit, which also includes capitation payments to MCOs that covers their admin, but we pay that through a benefits program. And then the admin, like Commissioner just said, that covers our salaries, our supplies, our contracts, things like that, that accounted for about 1.5% of our overall budget. Commissioner, that is all I have for today. And if you had any closing remarks, if not, we can move on to questions or comments.
Thanks, Steve. I do not have any closing remarks. I think it's been a lot of information, and we are here to take any questions you may have for us.
Appreciate the presentation, and let me preface any question you might have to just express my appreciation to you, Commissioner Lee, and to Steve. I think you do a great job for our program. I know you have real commitment to it, and particularly you, Steve, this fiduciary responsibility you have with this is certainly second to none. And I do remember the Bechtel pyramid triangle. I affectionately refer to it as the Bechtel Bermuda Triangle, but that's out of affection for you. You do a great job. A lot of information. We will have several questions, I'm certain. I'll start out with Representative Bentley.
Thank you, Mr. Chairman. I have several questions, but I'll start out simple. Mr. Bechtel, on the UK King's Daughter partnership that you talked about before, could you explain that to me again, the university directed payments on that $332 million?
Yeah, on the 332 million that I was talking about, the university directed payments, the reason why it increased was because at one time it was just UK and U of L, the two universities. But then when they had this partnership, we were able to, what the CMS allows us to do is to bring those people into our program. As long as they have a GME program, we're allowed to bring them in the university directed payment side of things.
Okay.
So basically the units, their services for their, we paid them a university payment program for their outpatient services as well as their inpatient. And so the outpatient services, they would have been able to count those into the program. Now, I will tell you this, they cannot get HRIP any longer. So they were getting HRIP at one time, both King's Daughters and Jewish and all that. But when they come into the university program, they can't double dip. They can only get it for one or the other program. So they moved into that university program, which is why the university side went up, but it probably had a teeter-totter effect on the HRIP program.
So Steve, if I want to try to paraphrase a little bit so you can correct me. So what happens with their university partnerships or university, the GME program, universities can pay us. We look at the services provided by their providers, and then we pull them in and we do some calculations. And so for services provided through those universities, they receive payments. We can receive additional payments from the federal government, from CMS, but the universities put up that state match. And those payments get them up to an upper payment limit. For example, they receive a little bit more money. ATRIP is different in that the universities can't participate in it because they're already drawing down those federal dollars, enhanced dollars for the services that are being provided through their facilities. So ATRIP is for those providers who are not in and not participating with that university GME program. So basically we're giving the universities a little bit more money, but they're putting up the state match in order to bring the payments, their Medicaid reimbursements up to either a Medicare or other upper payment limit.
So Representative Bentley, I don't want to confuse you any further, but I'll just say also that the university side, they pay what we call an IGT, which is intergovernmental transfer, which they pay the state portion right back to us. Whatever the state match was, that's what they pay us. That's what the universities pay. On the ATRIP side, it's an assessment. We are mandated by Federal Register to not exceed 6% of their gross revenues. So we have to do a beta test and everything on the ATRIP side to determine a per discharge amount to assign to that to help cover that state match, the state portion of those payments. I hope that doesn't confuse you any further. If so, I'll be glad to sit down with you and show you a little more.
Thank you very much. One more question.
Well, certainly, please.
Chairman. This is more like micromanagement here. I listened to my people in my area, and they said that the OBOT programs that don't prescribe methadone need a bundle code similar to an NTP or OTP. It's the only way they'll get paid. Is that true?
You're talking Greek right now to me. I'm sorry. When you say OBT, I'm not following what you're saying. Commissioner, do you have a response for that?
Yeah, I think you're talking about the outpatients, the substance use treatment. We do have different rates. We have different rates and different reimbursement methodologies depending on the specific provider type. I think what you're talking about is the methadone. Are you talking about the methadone clinics?
Yes, ma'am.
Mm-hmm. We do have a different reimbursement methodology for those. Again, we'd be more than happy to sit down and go through some of that rate methodology with you. I think there is an upcoming meeting that specifically devoted to substance use disorder and some of the coverage options there. So again, we'd be more than happy to put together a presentation outlining how we reimburse for our behavioral health services, including the outpatient treatment facilities.
You all did a really good presentation. Thank you very much for your time. Thank you, Mr. Chairman.
Just to remind the members who are participating remotely that if you have a question, please use the chat function and we'll recognize you. But we'll start with a question from beautiful Bowling Green, Kentucky. Representative Shelton has a question.
Hey, guys, and thank you very much, Steve and Commissioner Lee, for that presentation. I just got to say, you guys have done a remarkable job. When you start thinking about the number of programs that you've added over the last year or two, the increased enrollment, the okaying all the PAs, early refills, telehealth being expanded, all those things put an extra load on you guys. And you still were able to come within budget. And I'd be remiss in not pointing out something that sticks out to me, and that's you made a comment that your drug rebates were as large as you've ever seen them since you've been there, up to the tune, I think, of $850 million. Is that correct?
That is correct. Yes, sir.
Okay. And so I guess, I just want to congratulate you guys on the job you've done rolling out SB 50, because I do believe that rebate is as high as it is because it's something we all predicted would happen when you went to one single PBM, one formulary, and you're able to negotiate much more aggressively in these interstate commerce agreements. And I believe that led to some additional rebate money. And I think we'll see even more as we start nailing down this single formulary. So I would think that had a lot to do with it, but you guys can correct me with that. I think that was about probably 30-40 million more than what we would have expected otherwise. And but anyway, I just want to say I'm anxious to see additional costs come into that. There's a lot more to play with that, I know, but that was a good sign just seeing that. And I don't think that's that's any kind of accident. I think that's a direct result of the hard work you guys have done. And now from that point, I just want to ask one more question if I could, Chair.
Please proceed.
When you all decided to hire our single PBM, was there some reason that you decided to stay with a capitation rate rather than go with a percentage, since you're going fee for service, using a percentage? Because I feel like going with a capitation rate, when you did that, it left money on the table for the taxpayers to pay. And and I think you might understand what I'm saying. Is there some reason why we stayed with that fee for the capitation rate when it came to the single PBM?
I believe that one of the major reasons is ease of implementation. And this was the first time that we had ever done anything like this in the country. So again, brand new, we stuck with that because, again, ease of implementation. And Senate Bill 50 was implemented July 1st, 2021. So I think that we definitely need to keep an eye on it, do some monitoring, do some reporting to see how the true impact on the member, the provider, and the budget. And again, appreciate your all's collaboration on that. We've heard some really good things, not only in our within the Commonwealth, but externally. We have several states that are looking at what we have done. They really like the idea of having that single pharmacy benefit, but holding the MCOs accountable for the administration costs. But again, going back to the capitation, again, ease of implementation, and all of this was just brand new.
Well, that is a very honest answer, and that's probably, I'm sure it's the way I would have gone as well, given the time frame that you had. But I really do believe, just to look forward to the future, I think we've got millions that are still out there that we can look at in the coming years as we stick with this structure.
Yeah. And I think that Senate Bill 52 was just the very first step in reforming our pharmacy benefit program. I think we definitely need to keep an eye on it and continue to look at the impact. Again, because of ease of implementation, we had originally looked at tiering some of our dispensing fees. We didn't go down that route again because of ease of implementation. But I think that working together and getting information into your hands and the reports on the impact, I think that we can definitely identify more areas for improvement, not only in the pharmacy program, but other benefits as we move forward.
Well, thank you so much. And I appreciate the chair giving me some indulgence here. And thank you so much. And I'm here to help you in any way I can going forward with either tiered a program or whatever you want to do. And I'd love to discuss that capitation. So thank you so much.
And if I may be able to just say real quick, Representative Sheldon, I appreciate your comments about what we've done over this last year and a half. That list was not meant to be an exhausted list. There's a lot of things that's not listed on that list, and that our staff. But we can't sit up here, and I'm not going to talk for the commissioner, but I can't accept all of that on my own, because we're nowhere without our staff, and our staff are the ones that have really rolled up their sleeves and have really buckled down and been able to help us implement a lot of those programs. And to be honest, they're working remotely. So not a single service was delayed or anything by working remotely. And that tells us what we can do remotely.
That's great. And thank you so much for your presentation again. And one last thing, you guys get ready. It won't have anything to do with Medicaid, but for what we save the taxpayer and how we've been able to do it in the state, we want to do that also in the other sector, the other half of the prescriptions in the state. So you all get ready for that. Thank you very much.
Thank you, Representative Shelton, and certainly want to echo your sentiments regarding the changes here, and they have been substantial. And we've had a real paradigm shift in our thinking, because you recall when we first started having discussion about prescription drug prices that we were told that there's no savings, that it actually costs us money to do what we're doing. And now everyone seems to be on board that, yes, there's savings there and there's more savings. And I think we're on a good trajectory with that. So I appreciate that. I have a comment from Representative Frazier. Please, the floor is yours.
Yes, thank you, Chairman. I just wanted to echo the comments that Representative Sheldon made, and certainly acknowledge and thank them for all the efforts and all the programs they've put forth. But also just wanted to take the time to remind everyone that I would like to see us focus more on funding of community-based services as well, particularly adult day. The services can be less expensive and naturally allow the elderly person to remain in the home longer, until that time comes when institutional services are needed. But so I just wanted to put that out there, and hopefully we can expand that as well. So thank you.
Thank you, Representative Frazier. I've got a couple of questions, if I may. Steve, your last slide, Medicaid expenditure, is the one that Senator Alvarado doesn't like, and I share in his disdain for that particular slide, and I think you're going to know why.
Yeah, maybe I'll retire that from now on.
We won't let you retire it. I'm sorry. We would like to see, I think, expanded upon, and the reason I think that we don't like this slide is it truly doesn't recognize the total administrative expense for the Medicaid program, recognizing the MCO's portion. So surely somebody has identified for us, what is our total administrative expense for the Medicaid program?
Yeah, we can dig into that. The actual expenditures, I would have to look at some of the managed care's NAIC reports or get some data from them. But I will say that we always allow about a 10% margin at 90 MLR gives them a 10% margin to cover admin and profit margin. So it wouldn't be more than 10% unless they're losing them funds. But I would have to do a little more investigation, more digging into the data.
I'd appreciate if you do that, and don't mean to create work for you, but I suspicion that it may be a little bit more than 10%. And once you look at everything. But I have no way of validating that other than to know that we never have a lack of interest from the MCOs and want to participate in this program. So the profit margin has got to be quite substantial. And I think that's something that we need to look at.
Well, with the MLR, though, at 90%, if they are exceeding 10%, then they're actually losing funds because we are clawing back those funds that are not at 90% benefits.
So what I'm hearing that the committee would like to see is another slide, very almost identical to the fee-for-service, broken out only by MCO and what they're actually spending on it on benefits, their admin, and any other expenditures that are in there, such as any quality initiatives that they're doing or value add benefits. So that's what I'm hearing is another slide representing MCO.
Another question I have is on your per member per month slide. How does that compare to other states? Do we have any comparison?
I do not compare that to the other states, no, but I can reach out. I participate in with the National Association for Medical Directors. I do participate in a CFO affinity group where I talk with other CFOs around the nation. So I can reach out to a few of my counterparts and try to get something for you. I know that we have a presentation, which will be similar to this one next week with the Medicaid Oversight Committee. But I don't know if I'll have it by then or not, but we'll surely try.
Well, what are you doing this weekend? Just kidding.
I'm working on budget. I'm trying to get my for the next biennium. We're working on that right now.
Well, you referenced very early on that we're apparently the third poorest state, and that certainly does reflect in our Medicaid enrollment, and that in itself is tragic. I've said before, and I'll say it to my dying day, that I think the litmus test for any governor of the state should be the number of people we have on the Medicaid program. And I made that same comment when the previous governor was office, so it's not political. It's just from a taxpayer perspective. And I think we can do a much better job than we have been. You know that Senator Alvarado and I both have been promoting to do a different program rather than MCO, ASO. And when you see states like Connecticut, who had their ASO since I think 2014, I believe is when they implemented it, and their administrative expense ratio is right at 3%. You apply those same numbers to our program, if that's possible, then that's potentially $750 million in additional funding that we could use for other purposes, expanded benefits, or even increased payments to providers. So that's one of the reasons I'm interested in this expense ratio. And I just want to make sure that all of our committee members understand that the numbers that we're looking at for your budget does not reflect anything that we may do or consider as far as payment enhances for services. And I'm sure you follow our this committee meeting. We've had a lot of people before us this year, and everyone's singing this from the same hymn that they haven't seen rate increases for years. Our healthcare delivery system is very fragile, but just want to make sure that we all understand that your budget kind of reflects the world as we know it today. Is that fair?
That is correct. When we do our budget, we look at today and we trend forward. We do some trend analysis and some forecast, and we go through a consensus forecast group with the budget director's office, Budget Hicks's office. And so it is just looking at today. So any legislation or anything that you all do this upcoming legislation, it will not be included in my budget. That will be our request. So any additional budget that requires additional funding, we would need that additional funding in order to make that happen.
Well, personally, I think the best way to secure those additional funds is one, get people back to gainful employment where we're not covering as many people. But secondly, and you alluded to this as well, improve the health of our population. We were 47th, I think, a decade ago. We have moved up to 44. And I don't think that's because that our MCOs have done a good job. I think it's because we have more access to health care coverage under the Accountable Care Act. And the biggest potential savings is improving the health of the population, and we got to focus upon that. And I don't think we've done a very good job there. Another question I'd have for you regarding the administrative ratio is if you could to tell us how that might compare with what private insurance is doing.
I will do my best.
Yeah, I know.
The problem in that is whenever I do reach out to some of the commercial insurers, they always throw that proprietary word at me, and so I may not have the data to do that analysis.
Okay. We'll have a chance to discuss this more detailed at the next Medicaid Oversight Committee meeting next Friday. But great presentation. Always appreciate the dialogue with you folks. You're always open and candid with us, and I appreciate your testimony today. And look forward to continuing to work together. Thank you.
Thank you.
Thank you.
Going to move on to our second item and last item, which is reimbursement for adult daycare health centers. And we have Mr. Kelly Upchurch is here, and he's brought a guest with him. And I think they both know the routine. If you would identify yourself for the record, and you feel free to proceed.
Thank you, Chairman. I'm going to try to load. Let's see.
Well, while you're loading,
I was given instruction
Yeah.
before this started. She guaranteed me it was idiot proof, and we're getting ready to find out.
So you want me to come down there and do it? Huh? Is that it? Well, if you would, while you're pulling that up, just for the record, please identify yourself.
Yes, sir. My apologies. My name is Kelly Upchurch. I'm the legislative chair for the Kentucky Association of Adult Day Centers. Linda, if you'd like.
Hello, my name is Melinda Burchett, and I am the president of the Kentucky Association of Adult Day Centers.
Glad to have you both here this morning.
Thank you.
Okay. Let's see if this is. Okay, everybody. Can
Look
see
at
it?
you. You're there.
Okay. Well, first of all, let me thank the Subcommittee on Human Resources for allowing me to speak and for Melinda to speak. And we certainly appreciate the opportunity. I realize that there's not going to be as many zeros in my presentation as there was in the first one. But please don't think that diminishes the need and the importance of what we're going to say. But again, thank you so much for allowing me to testify. I'm going to start off. Some of you who heard me present on Monday, this is going to be a review of what I talked about then. The latter part is specifically to the point on human resources. But first of all, for those that aren't aware of the waiver programs, the community, the 1915C waiver services is a community-based alternative to institutionalization. We provide services using our services as well as natural support. So folks that are in the home, in the family members, caregivers, we assist them with and lift them up with services we provide, again, with the intent on keeping those folks out of institutional care. Home and community-based waiver services are the most cost-effective for that service. There are 5 models, which I'm sure you all have heard or will hear testimony for. ABI, Model 2 waiver, Michelle P., and SCL. The ones we're going to talk about today in my presentation is the home community-based. Home and community-based is part of the 1915 waiver. It provides assistance to elderly and to adults with physical disabilities to help them live in the community independently. All our patients that are enrolled, as I said on Monday, all these patients that are enrolled in this program could choose long-term care. We have 9,700 plus patients enrolled. All of them, if they wanted, could choose long-term care if they could find a bed. It's important to note that our efforts are to keep those folks in the home as long as we possibly can. Adult day services as a whole, there are 118 adult day centers throughout the Commonwealth. I'll make a asterisk beside that comment in that because of COVID, we don't know that number is 118. And I'll explain that in just a little bit. That could be much less than that. Adult day is the safety net for frail, elderly, and disabled folks. And what I mean by that is there's nothing in between us and long-term care. Adult day is the program that is designed to serve those folks that need and you've all seen this in with your loved ones or with folks you know. Senator Meredith in the hospital, I know you've seen this. Representative Bentley, I'm certain you've seen that in the pharmacy industry. And certainly Senator Carroll, you've seen this in your own adult day center. But folks that need just some help during the day, just need some assistance during the day, are first forced with horrible decisions to make, family members, horrible decisions to make. What are you going to do with that, with your mother, your father, your aunt, your uncle, your husband, or your wife, when those folks just can't hardly make it in a day without some assistance? You might have a job, you might have other health issues that you can't physically take care of them. What are they going to do? Adult day steps in the gap and helps those patients do that. Adult day steps into the gap and helps those Kentuckians that just need that type of help to postpone or eliminate their need for that long-term care. It's an all-inclusive model. There's no a la carte type of services. When we admit a patient, we take care of that patient. We don't trim off other services that they might need in the adult day setting. For instance, if they need an injection, we don't charge them extra for that. If they need a bath, we don't charge them extra for that. If they need wound care, we don't charge them extra for that. It's one fee for service. Our fee right now, and don't want to stun you, for adult day within the boxes of the adult day is $11.32 an hour. $11.32 an hour. Folks, I don't know if that number stuns you like it does me when I say it out loud, but you can't get someone to flip your hamburgers for $11.32 an hour. We can do that in an adult day setting because it's a congregate setting. We bring those folks to our adult day center. We have nursing staff and other healthcare providers in the adult day center. We provide that service at $11.32, and by putting those patients in a congregated setting together, we can manage their care better. And we can do that for that lesser amount than you would expect if you were hiring a nurse or hiring a professional to come in and do one-on-one services. Patients that come to our adult day, as I said before, all meet nursing home level of care. Adult day health care is in a home and community-based setting is the only service that requires a skilled service for them to be admitted. Some of the things that are in our facilities, some of the things you're going to see going on, of course, is skilled nursing care, medication management, chronic disease care, wound care. I intentionally skipped in-home attendant care. I'm going to talk about that in a minute. All trach care, urinary catheter care. We provide PTOT and speech, nutritious meals, case management services, day supervision, socialization, respite, and transportation services. We also provide out of the four walls of the adult day attendant care services. Those services are non-skilled services. We come into their home and we assist patients that need help with bathing, grooming, light housekeeping, meal preparation, all those things, folks, that you would need if you were seeking services for your mother, your father, your grandmother, your grandfather, your husband, or your wife. All those services you would be seeking, adult days can provide that service in attendant care. So those services we provide too. And by the way, that reimbursement rate is $24 an hour. Both of those rates that I give you, the last rate increase we got was in 2016. And I know, Senator Merritt, as you alluded to earlier, it's true. Everybody is here saying we haven't had a raise in a long time, and that doesn't escape me. Our function and goal is to take care of people. We're asking, of course, and everyone here is asking, is just the ability to do that without just eliminating a service line altogether. So what does it cost you for that? I mean, we could put a value on it right now. I would ask you, what would you say that is worth? Here's what it costs the people of the Commonwealth. You see ABI and ABI long-term care, Michelle P, SCL, and nursing facilities long-term care. The one we're going to talk about is the home community base as it applies to adult day. We served in the 2021 fiscal year 9,713 patients. It cost the Commonwealth $198 million, almost $199 million to do that. Not all that, as you're aware, comes out of the general fund. The cost per participant is $20,479.71. When you and I'm mindful that these are taxpayers' dollars, and and it really does beg the question: where are you getting your money's worth in the home community-based waiver? My opinion is adult day health care. You know, when you talk about the services and the services that we provide, I can't think of another service that can do it cheaper than us and deliver the quality of care that adult day health care is providing for $20,479 per person per year. I put it in a pie chart, and everybody loves pie. And that's just another picture of what the services are and how much they're costing the Commonwealth. Adult day health care's response to COVID-19. I want to throw this in there just because everybody has an idea about what is going on and what services are. As some of you know, in March of 2020, adult days through the mandate were shut down. We almost immediately had to figure out how we're going to take care of our folks. How, if they can't come to the adult day center, what are we going to do? And I'm very proud of the reaction and response that adult day healthcare provided during this crisis and continue to provide during this crisis. We almost overnight, from a Friday to a Monday, shifted all services for 9,000 patients from the adult day setting to a in-home attended care setting. We made sure that those patients that would possibly fall through the cracks, those patients that are receiving skilled care, continue to get that skilled care in their home. Now, here's the trick. It's not a magic trick. It's a little painful to even say, but we would send our staff and continue to do that in some cases into that person's home for $11.32 an hour. And if you're in the healthcare industry or you know someone who is, most RNs are reimbursed at around $30 an hour. It makes it very, very difficult to deliver care. But we did that, and I'm very proud of our industry for doing that. We provided non-emergency medical trips to doctors' offices, to vaccination sites. We acted as vaccination sites in some scenarios. And we provided, as I said earlier, in-home skilled nursing care for $11.32 an hour, and some are still doing that. One of the things that we stepped up and did, and I want to applaud the cabinet for allowing that and being forward-thinking and doing this, but one of the things that we have done, just adult day facilities, this is just our target. Of course, that number is somewhere around 5 million, but adult day provided 776,000 meals to participants in their home. The reason why that's important is meals are part of the service in an adult day setting. A lot of the adult day patients come to the adult day, and part of the attraction of that is there is a meal that we provide. So not coming to the adult day would mean for a lot of our patients no meal for that day. So we did step up, and 776,000 meals to a group that really is not prepared to deliver 776,000 meals. I'm pretty proud of their reaction and their response. We were also very fortunate and very appreciative of the cabinet for some retainer fees that we were given during this pandemic when we were shut down. It was a little less than $5 million in retainer payments. That equated to about 2.3% of our total operating budget. Some of the impacts that we've seen of COVID statewide, and please know this is not a scientific study. This is just me on the telephone calling up our adult day colleagues and asking them a series of questions. Some I could not reach on the phone, and I got bounce backs from their emails. That's why I say I don't know if there's 118 still here. But of the ones that I could reach, and I don't want to paint a bleak picture, and I hope that I can paint a better picture at the end of this discussion when I answer questions. But right now, we know without a question they're permanently or will close permanently 4 adult day centers. There are 8 centers that had questions of whether they were temporarily closed now, whether they're going to be able to reopen. They remain shuttered, and whether they're going to reopen, they are just uncertain of whether they're going to do that. 60% of the people that I called on the phone that I talked to in the survey said that they were experiencing a 50 to 75% decrease in adult day daily attendance compared to pre-COVID numbers. There was 30% of the response said that 25 to 49%. The primary reason for this, folks, and it comes back to providing services in a congregate setting. The adult days reported the distancing requirements and the patient's inability to mask as the primary difficulty with those folks coming back into attendance. And that shouldn't shock anybody. That's not a surprise. And we're not, please don't take this the wrong way, we're not opposed to any of those restrictions. I think it's keeping our folks safe. There's not been a single, by the way, to my knowledge, a single contact traced COVID patient traced back to an adult day setting, not one, in the 18 months that we've been under the gun. 100% of the respondents reported difficulties in hiring and retaining staff. Folks, we are in a crisis right now, and I know I don't have to share that with this committee because you're painfully aware of that. We have to be able to pay a decent wage to have someone work for us, and that's just the bottom line. We just have to be able to do it. Recommendations, very direct recommendations, I know, and I put this together. This is quite a moving target sometimes because there's a lot happens just between the 8th and today. But what we're asking is that those ARPA funds be directed to adult days to keep them competitive in being able to recruit and retain employees. We're also asking the one-time ARPA funds be granted to assist adult days in recovering from the COVID-19 related losses. Certainly restrictions from of 6 feet restrictions and masking has done its damage for a lot of providers, but certainly has impacted us as well. We're asking for a adult day rate increase, both adult day and attendant care of a 10%. As I said earlier, the last rate increase that we obtained was in 2016. Folks, that 10% rate increase, although that number seems big, that really doesn't even keep up with the inflation rate of 2.23% since 2016 to date. So we're really not even asking to be kept up to the inflation rate here. The final thing that we would like to ask this committee, humbly ask this committee, is that the legislature consider implementing some type of continued funding strategy every 5 years or every 7 years. I know some of you are tired of seeing me if you've been around that long. You see me come before this committee and I ask for a rate increase. If we could find some way through developing a strategy to ensure the viability of adult day providers in this next budget, I would be just thrilled to work with the legislative body in developing that. As I said, on behalf of the Kentucky Association, we thank the committee for the opportunity to testify, and I would be happy to entertain questions.
And do appreciate that great presentation. I did hear it earlier in the week, but it's certainly an important service to us. And I think one of the struggles is that we don't recognize a continuum of care, that each service is almost like a kingdom in itself. And we kind of look at each other as competitors, and we shouldn't be. I can assure you there's enough business out there for everybody, and I think our focus has to be on the appropriateness of care. And if you're taking care of a patient in adult daycare, that doesn't mean you've taken a patient away from the nursing home. It just means they're in the most appropriate level of care. If we do that, there's tremendous savings that come from that, and I don't think that we recognize enough. But we have 6 minutes left. I'm very sorry that we have to cut this short, but we got another committee meeting. So I do have some questions. Let me start with Representative Prunty. You have a question?
I did, but he answered it in his presentation. I guess the question I would have is, what happened to those patients that didn't get to come to adult daycare because they were shut down? I mean, did they ultimately go in nursing homes, or do you know?
Representative Prunty, we know that the adult days that moved to a in-home model, those patients were cared for. Those adult days that shuttered and could not provide that service, I don't know what happened to those patients. I would imagine that they probably, I would be remiss in saying that they went to the nursing home, but they certainly during that period of time would not have wanted to go into the nobody wants to go in the nursing home, but you certainly wouldn't have wanted to do it during that period of time while COVID was rapid through, was sweeping its way through the nursing home community. So a lot of those folks receive services by adult day providers in home, and we tried to make up the difference in skilled care by sending nurses to their home to do it.
Well, you know, the problem we have in America is everybody wants the best health coverage that other people's money can pay for, and we don't appreciate it until we have it ourselves. And then, yeah, we have to have it, and we expect a quality service. And I'm quite concerned about all healthcare providers, but particularly the long-term care industry, because they're facing even more severe manpower shortages than possibly even you folks are dealing with now. And what happens if those facilities close? You know,
Yes.
You'll pick up some of that business, I'm sure, but I'm not sure there's enough to take care of everybody. But
And Senator Meredith, I just want to add this. I know we're short on time, but the Adult Day Association is not anti-nursing home. If there is a need for 24/7 care, there is not a better place for them to be. And Kentucky has some of the finest nursing homes in the state. What we're saying is that there's probably over 600,000 Kentuckians that are age 65 years of age or older. Those Kentuckians are getting ready to enter into the healthcare system, delivery system. And I agree with you. If we can work together without having silos, there are plenty of patients that need us to deliver care to them. So I wanted to clarify that.
should be. Thank you. We're down the last couple of minutes. I've got one question, and then I'll end with Representative Bentley. Senator Berg asked, why would adult daycare be covered under medical insurance?
Medical, why would it? Were you the Medicaid program or just medical insurance?
She said medical insurance.
Adult Day, because Adult Day provides a skilled healthcare service. All those services that we provide, I would certainly wish they would be picked up by a lot of other providers. Certainly, long-term care insurances have been paying for Adult Day services for probably 20 years. But there are some other insurances that pay for Adult Day services. It's not being picked up by, of course, long-term care is not picked up by insurances either. So.
Right.
Medicare has made some subtle attempts through supplemental insurances to cover, but that's not very wide sweeping. It's very limited. We're hoping that will obviously come to fruition more fully.
Here. Representative Bentley, you have the last word in this meeting. All right, thank you. Great presentation again, and we certainly understand the importance of adult daycare within this healthcare continuum, and we want to try to help all of our providers. Not sure what that looks like from a practical standpoint, but again, focusing on spending their dollars wisely, improving the health of Kentuckians is where we have this great opportunity, but your message has not fallen on deaf ear, and look forward to the next budget cycle to see what we could possibly do.
Thank you, Mr. Chair, and we thank the committee for the opportunity.
Thank you. Great presentation. All right, our next scheduled meeting is October 6th, and members, as usual, you made available online for downloading. And with that, do I have a motion to adjourn? So moved. Is there a second? I see Senator Carroll's second. He's nodding his head. You can't see that in real life, but it is. All in favor say aye.